today I want to discuss about the complications of diabetes. Why you are afraid of diabetes? Many times you find that a patient with significant hyperglycemia would not have any complaints. He or she will simply walk to your clinic, and after medications or prescriptions, he or she may go away. But we are afraid of diabetes because of its acute complications and long-term complication. And today my discussion will actually focus on the complications of diabetes, the long-term ones. And we can divide the long-term complication of diabetes to two major groups, macrovascular and microvascular. So in the macrovascular, we have the cerebrovascular disease, heart disease, different heart disease like atherosclerotic heart disease, peripheral artery disease, and ulcers and amputations, which happens in the lower limb mostly because of ischemia, limb ischemia. On a microvascular front, you have the classical three, the retinopathy, nephropathy, and neuropathy. And sometimes food problems because of both micro and macrovascular complications. So today my focus is actually on diabetic kidney disease, and I will give you some statistics here. Actually, is the most prevalent chronic complications of diabetes mellitus and one of the most dreaded ones, with high mortality and huge morbidity and huge economic burden on the society as well as individuals. Almost 30 to 40% of patients with diabetes mellitus develop diabetic nephropathy. We divide it from stage 1 to stage 5, but if you include all of them, it's about 40%. And a single leading cause of end-stage renal disease now. We keep aside all the other diseases like CGN, hypertensive nephropathy, etc. They are on one group. And this group is another group, which is the most common group of end-stage causing end-stage renal disease. And they're at a high risk of progression of chronic kidney disease to the end stage renal failure stage, and they're also at a high risk of dying of cardiovascular or cerebrovascular disease. So it's called a CAD equivalent. I mean, having chronic kidney disease, advanced chronic kidney disease, just like already having an MI or a CVA, which makes you highly susceptible for another cerebrovascular cardiovascular event. And there are few things which are very important, like healthy versus diabetic kidney disease, where in diabetic kidney disease there is mesenchymal proliferation, injury to the podocytes, which leads to poor glomerular functions, and there is collagen deposition within the mesangial cells, which are hypertrophied because of changing milieu of the glomerulus. And there is also change in the basement membrane. There will be thickening of the basement membrane, and there will be arterial hyalinosis and afferent arteriolar dilatation, causing more blood to flow into the glomerulus, and efferent arteriolar constriction, which will not allow the blood to go out of the glomerulus, causing intraglomerular hypertension, which leads to single nephron disease or single nephron damage. And when a critical number of nephrons are destroyed, the total capacity of the kidneys to filter out all the toxins as well as the water is decreased significantly, and then edema sets in. And because of glomerular injury, podocyte injury, there will be albuminuria. And these are two major ways of where the kidney goes into a chronic failure stage. And this picture actually particularly shows the difference between a healthy kidney and diabetic kidney disease, where the main important points which I have already mentioned. Apart from them, there are also tubular epithelial atrophy, which is seen prominently in the diabetic kidney disease, and there is influx of inflammatory cells, which you can see in this particular diagram. What are risk factors for development and progression of diabetic kidney disease? So there are modifiable risk factors like hypertension, poor glycemic control, and a degree of proteinuria also can be modified by dietary control and certain drugs which help a lot. Smoking is another modifiable factor. Suppression of RAS. RAS activation is a important parcel of the diabetic kidney disease progression, which can be suppressed by medications. Anti-RAS agents are quite available nowadays. And elevated cholesterol also indirectly, contributes to the progression of diabetic kidney disease, which can be controlled very nicely by use of statin. Non-modifiable factors like genetic susceptibility, certain groups are susceptible because of inheritance of certain gene. Duration of diabetes, we cannot undo it. If the person is diabetic for 10 years, he's diabetic for 10 years, so we cannot undo it. Male gender is also susceptible. We cannot change the gender. Ethnicity, certain ethnicity like Black, Asian, Hispanic populations are more at risk than the Caucasites, so we cannot change it. A person is born Hispanic will always be a Hispanic. So pathogenesis of diabetic kidney disease, it starts with hyperglycemia. For hypertension, it is hypertension, and for diabetes is hyperglycemia. Of course, a person who is diabetic as well as hypertensive, he has got a more rapid progression of the disease, because hypertension contributes immensely and adds onto the ill effects of hyperglycemia. And that leads to very rapid progression of kidney disease in diabetes mellitus. So after hyperglycemia, you have the RAS activation, then protein kinase C activation, and then it leads to the expression of growth factors and cytokines like TGF beta, PDGF or VEGF, which finally causes endothelial injury and extracellular matrix expansion, and that leads to glomerular basement membranes thickening and podocyte injury. And in the meantime, the formation of advanced glycation end products are also responsible, and oxidative stress, which is very common in diabetes mellitus as a whole, is also responsible. And finally, all these lead to causation of diabetic nephropathy. And if you look at nephropathy and the relationship of morbidity or death, like if there is no nephropathy, it's just like other population, like 1.4%. If the patient has microalbumin rates increases, so 3%, it's almost twofold increase. Then macroalbumin stays 4.6% mortality, and when the patient reaches stage 4 kidney disease, elevated serum creatinine, or patient on renal replacement therapy at the stage 5 kidney disease, mortality is 19.2%. That's almost 1 out of 5 patients at this stage are bound to die in next subsequent years. So that's very alarming. We must stop the progression of stage 1 kidneys, stage 2 kidneys to stage 5 kidneys, because stage 5 means there is 1 in 5 persons are going to die. So kidney disease in diabetes patients is clinically characterized by increasing rates of urine albumin excretion. So normal albumin rate is a stage where the excretion is less than 30, and microalbumin is 30 to 299. When it reaches 300, we call it macroalbumin. It's a point of no reversal. If the protein excretion is more than 300 gram per milligram of creatine, then it's a point of no reversal, and that patient is highly susceptible for the development of end-stage kidney disease. And this is one of the major pathophysiological mechanisms by which this whole cascade would start. But I'm not going to details of it. It's a podocyte injury, as I said, and there are various mechanisms by which we can actually try to prevent this podocyte injury, but nevertheless, it's not 100% successful always. Finally, while treating diabetes kidney disease, we have various medications, but it's only insulin which is considered safe, used in right dose and right titration. It is the safest molecule, and once the patient develops kidney disease, say upon stage 2 onwards, it's always preferable to put the patients on insulin, because glycemic control at every step is very important, and only insulin can give it safely. Of course, insulin can cause hypoglycemia. That doesn't mean that we should avoid insulin in all these patients. We have to titrate the dose carefully. We have to use small doses, small quantum of increments, because they are susceptible to hypoglycemia. So hypoglycemia happens because of poor titration, not because of insulin. So one should not actually blame insulin for that. So these are the stages of kidney disease, like I can say that EGFR, GFR, glomerular filtration rate is more than 90 milliliter per minute per 1.73 meter square body surface area. It's called normal. Between 60 to 89, we call it mildly decreased EGFR or GFR. It's stage 1. Moderately decreased GFR is 30 to 59. We call it stage 3 actually. And this is above 91 is stage 1, 60 to 89 stage 2, 30 to 59 stage 3, which can be divided to stage 3A and stage 3B. Stage 3B is 30 to 45. Below 30 is severely decreased eGFR. It is the actual advanced kidney disease, almost a point of no reversal. It's 15 to 29 or 15 to 30, you can say it's a stage 4. And below 15 is the stage 5 or end stage renal disease, where the patient usually requires dialysis sooner or later. Some of them go for renal transplants. So as I said, there are various medications, the early stages which are approved, like DPP4 inhibitors, GLP-1 receptor agonist, and SGLT2 inhibitors, which are of course helpful, but nevertheless in advanced stages, across the various stages, insulin is considered to be very safe. So with this, I would rather thank all my audience for patient hearing, and thank you very much.